Hello, everybody. I'm David Eisenson. I'm with RightPoint, and I played a role in organizing tonight's panel. And I just wanted to say a few words and thank everybody for coming out. I think this is a really great topic. I think it's going to be a really interesting panel. We've got some fantastic senior experience that's going to be sitting up here and sharing insights and opinions. Just really thrilled. This is a space that we as an organization are working more and more in, and seeing how not just the healthcare industry is changing, but everything that touches the healthcare industry, how it's becoming much more personalized. So very excited to introduce these folks to you. So let's start with Ben and turn it over to him.
Hey everybody, can you hear me? Awesome. Really excited to be here. If our panelists, you guys want to come on up? Great. So we have a fantastic panel, and as David said, my job's going to be really easy. It's going to be a awesome discussion. I'm really looking forward to leading it. So my role at RightPoint is I'm the Vice President of Mobile and Emerging Tech. I focus a lot on mobile apps and how to better build those for businesses. I've done a lot of work in the healthcare space and specifically focused a lot on innovation as well. But I think you're all here not to talk to me or hear from me, but to hear from these great panelists. So I think to just get things started, we'll just go down the row and tell us a little bit more about who you are, your current role, and what you're excited about.
Okay, great. Thanks everybody for coming out tonight. I'm looking forward to a great discussion. My name is Louise Short. I'm a physician by training, internal medicine, occupational medicine, and preventive medicine. And I'm the national clinical leader for Brown & Brown Insurance. And you're probably wondering, what is an insurance person doing talking to you all today? So I run the population health practice for Brown & Brown. Brown & Brown is a $2 billion property and casualty and employee benefits brokerage and consulting company. And I'm the sort of lead for the health consulting practice. And what we do is we help employers figure out what their strategy is. And a big part of that strategy today is figuring out how digital solutions and digital therapeutics fit into their overall framework in terms of improving health for their employees and dependents, improving productivity, improving the medical trend in their self-insured health plans. So I also run an innovation center for Brown & Brown, which we started last year. And our goal is really to catalog and evaluate many of the digital health solutions in the marketplace in order to be able to help our clients figure out which of those will best work with their population and be consistent with their strategy. And I live here in Atlanta. My background, I've spent many years working for healthcare carriers, so United Healthcare, Anthem. I've worked for health vendors. I've worked for the CDC and been in clinical practice. And I'm delighted to be here tonight.
Welcome. Steve, you want to go?
Hi, I'm Steve Martin. I got a note publicizing this particular event that said, quote, "Join us for what's new and hot in med tech." And then I asked myself, what the heck am I doing on that panel? Because I'm certainly not new, and my wife is the only one who says that I'm hot. And
It's good that she says that.
well, now that I think about it, I haven't heard it lately. But I guess I was included to maybe give some historical background, and if that didn't work, then maybe some comic relief, although my King Tut routine and my banjo picking are just absolutely terrible. If I have any claim to fame, it's that in 1980, like I said, not new, I convinced Ciba-Geigy Pharmaceutical, which is now Novartis, into letting me start a brand new, from-scratch business here in Atlanta in soft contact lenses. At one time, I was the only employee of Ciba Vision around the world, and we had 0 sales. And when I left the operational management of the company, we'd grown to 6,000 employees, and we're doing $1.2 billion a year in sales. I guess as far as what I'm doing now is This is my third retirement, but I'm still sitting on several boards of directors, and I just joined 2 advisory boards in this last month. And I'm also a CEO partner with Steve Bachman there in High Tech Partners, and we help entrepreneurs get off the ground and do some consulting and mentoring, among other things.
Great. Thanks so much, Jeff.
Great. Jeff Gartland. I'm president of Ciox Health. 20 years in healthcare technology. The last 10 or so, I've been deeply embedded in the problem of interoperability. So I've been involved in everything from claims transmissions from providers to health plans through patient portals, and most recently really around the problem of clinical interoperability. I was at the beginning stages in developing what's now called the Commonwealth Health Alliance, which was designed to bring various healthcare technology vendors together to try and drive more ubiquitous plug-and-play data exchange. And for the last 2 years, I've been with Ciox, which is the nation's largest entity that's really involved in managing and aggregating the last mile of interoperability. And a little bit around what Liz was talking about, for those of you that aren't aware, the average hospital has 17 different EMR systems. That doesn't even take into account the departmental subsystems like radiology and laboratory, behavioral health, cardiology systems that are departmental within there. And then obviously you have the entire breadth of paper medical records that still exist in a lot of places that need to be aggregated together. And so we really spend our day trying to homogenize the chaos that is a person's clinical information and aggregate that and provide that back in digestible fashion. And so I'm excited to be here to really talk around how do you make it real? Because in my 20 years, there are some fantastic applications and analytics and mobile utilities and all of those kinds of things. But at the end of the day, if you don't have the data flowing, it doesn't work. So that's really where I focus my time.
Very cool. So our panel kind of the topic talks about somewhat facetiously taking 2 apps and then calling your doctor in the morning, which I think we all kind of chuckle at, but maybe is becoming a little bit more of a reality. So Jeff, given you talked about some of the interesting apps you've seen, maybe we'll start with you. What are some of the apps that you're seeing or uses of mobile devices in healthcare that are exciting to you, that are coming down the pipeline?
Yeah, a lot of the apps that I see that are most exciting are ones that are really patient-centered. How do you get the patient at the center of their care? Whether it's through regulation or whether it's through other market forces, the reality is that we are driving towards a more consumer-oriented mentality versus a patient mentality. And as you drive that consumerism, the onus becomes more on us as individuals or our families as a part of that care team to really navigate and drive our way through the healthcare ecosystem. So I really enjoy a lot of the apps that are more patient-centric. Yeah. There's some fantastic ones out there. There's ones that go from patients like me that's really oriented around how do you get tighter cohesion around support groups, if you will, around particular diseases. And then all the way through, we were talking in the back a little bit around some of the behavioral health and other kinds of things. In my background, I did some work with the Department of Defense, and there's some fantastic things that are going on as it relates to things like PTSD, and how do you actually manage that on an ongoing chronic basis so that you can prevent things from getting to a particular point. So I think those patient-centered ones are the most fascinating.
That's cool. Louise, you want to talk about maybe an app that's interesting to you, or?
Sure. So I think there's a lot of noise in the marketplace, obviously, and there's sort of in my mind, 2 types of apps. One are the health and wellness apps, kind of like the trackers and logging your food and taking pictures of your food and all of that, and exercise. And then there are more of the digital therapeutics apps that are actually trying to deliver therapies. And so a lot of the digital therapeutic apps are related to virtual care, and I really think that is the way that medicine is moving today. And there's been a recent study by Accenture looking at consumer digital health behavior, And for the most part, the conclusion was that for Generation Z and millennials especially, they are not interested in traditional delivery of healthcare. That's very low on their priority list. They're looking for digital solutions. In terms of the areas where we see virtual care, there's sort of 5 or 6 main areas. The first one is sort of urgent visits, like I have a cold, I have a headache. How many of you might have like Teladoc or something like that as part of your health plan? Have you used it? Yeah. What did you think?
It was very interesting. It was great, though. It was like fast and they delivered to the pharmacy what we needed.
Exactly. They can prescribe it. So that it's very, very convenient. It's taking on more and more. More employers are delivering that type of a service to their employees because they want to reduce inappropriate ER utilization. And a lot of health plans now are offering telehealth as part of their services. So that's kind of the first area. The second area that's very big is behavioral health, as you mentioned. So behavioral health visits and ongoing therapy in behavioral health. Previously, it was just kind of like consults, but now it's ongoing therapy. The third area is virtual PT. So there are a couple of companies that have put together technology with sensors where a virtual physical therapist can actually, or coach can actually figure out if you're doing exercises the right way and correct you. And when you think about it, PT is a big drain. I mean, you're going 2 or 3 times a week. It's inconvenient to get there. Your employer doesn't want you to leave work. So these types of solutions are really taking off in the marketplace. The other 2 areas are women's health. So I don't know if any of you have ever heard of Obia or Wildflower, but these are apps that present a lot of information to women about pregnancy. You can track your pregnancy, and some of them have back ends that go into a health plan where you can integrate with care management. Like if a high-risk pregnancy is identified, then a care manager will call out. So that's another area that's really taking off. And then I think the last area is diabetes and metabolic syndrome. So diabetes, Livongo is a cloud-based monitor. And so the readings go up into the cloud, and you can share those readings with a care team. And there are alerts if your sugars are too high or too low that go to a call center, and you'll get a call. And if you agree up front, which we can talk about use of data, they'll call 911 if your sugar is too high or too low and you don't answer. So that's a very interesting one, and one that's catching on with a lot of employers, and it's not that expensive. And then metabolic syndrome, pre-diabetes. This has been one of the areas that's gotten sort of the most publicity, and I think really the area that's taken off very quickly. Pre-diabetes, what's been shown by the Diabetes Prevention Program, which I don't know if you all know the literature, but it's a scientifically based program that's shown that you can reduce the risk of progressing to diabetes by 57% by modifying risk factors. And it's a landmark study. And so Omada Health has taken that and digitalized it and also put virtual coaching in place. And they've had pretty great success with it. I think they're now, Medicare and Medicaid are both using Omada, I believe. And there are several other solutions like Virta and Real Appeal, which is United Healthcare's version of Omada, that are also in the marketplace. So part of what I do is kind of help employers figure out, and make sense of all of these solutions, because they're all calling employers all the time trying to kind of get into the front door. But there are a lot of great things out there that can really improve health today.
Steve, on the pharma side, I know there's some really fascinating stuff that is going on in terms of the app space.
Sure, and wearable health monitors are certainly catching on big. Just to point that out, there's last year 122 million such devices with their attendant apps were shipped worldwide. But the fact is that up until this particular point, most health care in this country has been sick care. We assume that we're perfectly healthy and that nothing wrong is going on inside us here. Until that day, we take that ride to the hospital in terrible pain and find out there are a whole host of things that have been going wrong during that time. With wearable health monitors, we should be able to know those things ahead of time and be able to avoid maybe that trip to the hospital. I would like to mention just a few of them that kind of caught my fancy. Vital Patch from Vital Connect out in San Jose. Are you familiar with them? It's basically a bandage-like device, a Band-Aid that's about 4.5 inches long and weighs the same as 2 nickels. And it monitors real-time 8 different vital signs that you've got and transfers those to whoever the caregiver is. FDA approved it last year for both in-home use as well as in hospital use, but most of it, I think, is being used in the hospital. Is that your field too? Apple Watch 4. You know, we're all familiar with that one, but it can send ECGs and vital signs and your stress level to your iPhone or your doctor's iPhone or your caregiver's iPhone. I don't have Apple Watch 4, I've got Apple Watch 3, but if I get up anytime during this panel meeting, it's probably because my watch told me it was time to stand. There's another one that is on the market right now. It costs about $300. It's called ORA Ring, and it looks like a wedding band. And you slide it on your finger, and it tracks your sleep. And it tells whether or not you're in REM sleep or how long you spend in deep sleep and how many times you turned over and what position did you wind up in and what was your body temperature during that period of time. I happen to be involved because I joined the advisory panel of a startup here in the Atlanta area that's not on the market yet, but iCheck is an early stage company that is developing a contact lens, an active contact lens that gives out a certain amount of fluorescence depending on different factors, and you can hold your iPhone up to it and it can tell you what your blood sugar level is without you having to stick your finger. It also can tell you, for a totally different market, it can tell you what your potassium level is, what your chloride level is, what your sodium level is, and what your degree of hydration is, which is great for real athletes or wannabe athletes. They're in the process right now of raising some additional funds, but I think this is going to be a great boon to all of us. I have to stick my finger twice a day, and I'd just as soon not. Another one that's not really on the market yet, but in April of 2017, Qualcomm holds a contest called the X Prize. And they granted $2.5 million to a company in Philadelphia that has come up with, these are not wearables, but a shoebox-size collection of sensors that can monitor 34 different conditions and diagnose them, and 5 different vital signs on you. Really interesting. I think with the kind of money they've got, they're going to be a real player. But it will probably be going back more to institutions than it will be to an individual doctor.
So we've got so many amazing apps and innovation coming down the pipeline. I mean, how do you guys think the patient experience is going to change with all this? I mean, I know, Jeff, you talked a lot about the data interoperability, but you know, how can we, you know, seize this this future of all of these apps working together harmoniously? Is that going to work? Or?
Yeah, it's interesting. So, you know, as we talk about the different things that are out there, and there's probably 5,000 other ones that are out in the marketplace, I personally foresee a real challenge right now, which is most all of that innovation is more what I will label as consumer-friendly versus enterprise-ready. And there are aspects of that transition, that maturation of the market from consumer to enterprise-ready that we have yet to actually accomplish. Part of that is regulatory. So, for example, some of them have gotten FDA approval. You've leaped over some hurdles there. But there's many, many, many more hurdles that really challenge the adoption rate of those capabilities and those applications. So there's challenges like, okay, I've got these fantastic readings of my life down to every millisecond for the last week. Does anybody actually care to read all of that data? Okay. Which parts of the data are really relevant? Is it every single time I stood up or breathed? Or is it those ones that actually show some level of abnormality? When that data is coming back in as a care provider, do I incorporate that as part of the patient's longitudinal record? Or is it just something that I look at for some interesting insight? And what are the regulations associated with whether I do pull that in as part of the record? So there's a whole series of maturing steps as an industry that we're going to have to really work through and go through in order to make those applications truly enterprise grade. And I think we'll see a lot of them not proverbially cross the chasm, if you will, and fall down in that process. But there's definitely going to be some that leap over there, and there's probably going to be an entire new set of innovations for companies that try and bring that and harmonize that together. So just like Liz spoke to before, how do you bring all these 10, 15 different portals together? There's an inverse of that too for a provider. Where do I go to as my home if I'm a physician that allows for me to see the breadth of my patients and all of the different apps that they may be using? That will likely, in my view, be easier in certain specialties and niches. So you can narrow that down to diabetes care. You can narrow that down for cardiology, for oncology in certain ways. That'll probably allow for those ones to move a little bit faster. But when you step back and think about primary care, when you think about an internist, an externist that's managing care post-discharge, I think those are going to be a little bit more complex because that's really where you're getting into how do I touch each and every facet of an individual's life and how they've interacted with the healthcare ecosystem. And so I think it will be an interesting challenge for us as an industry to see which ones can get to that enterprise, that true enterprise grade kind of view. Yeah. And then how do we see a flourishing of different technologies that help harmonize all of these innovations that are spun out.
Louise, I'm curious your perspective. So, let's assume we've got these enterprise-level apps that are collecting all this data. Is there a scenario where employers start to act on that data in ways to incentivize behavior or, track things? Like, what are you seeing? I mean, is that already happening?
It is already happening, though not so much from apps, but I think apps will facilitate it more. Like, a lot of employers have what we call outcomes-based incentives, so they'll do a biometric program, and employees will either get money or gift cards or premium reductions if their biometrics are within a certain level, so your glucose, blood sugar, your weight and your cholesterol, and also for smoking cessation. The employers have been a little bit reluctant because the EEOC made a ruling about 1.5 years ago saying that it might be discriminatory to give people these types of outcomes-based incentives. And when you think about it, if someone has a BMI of 40 and you're getting the incentive if your BMI is 27, how in the world are they going to get from 27 to 40? So now the ruling is that you have to have a reasonable alternative. So say someone is a smoker, so they don't get the non-smoking incentive, but if they participate in a smoking cessation program, they can still get the incentive. So, but that biometrics is just one example, but there's so much data now that you can imagine that employers could incentivize based on a lot of other things that are coming through, on a lot of other types of data coming through in these apps.
Well, let's talk about data for a second. So I know last Monday, and Jeff clued me into this, there were some pretty seismic changes to the regulatory direction. You want to talk a little bit more about what was Health and Human Services released?
Yeah, sure. So just a baseline on that topic, I'm not sure how many of you all recall about 10 years ago, the stimulus ARA Act, and it had a few thousand pages buried in that called High Tech that basically set the direction for about $30 billion worth of spending that came in the first Obama administration to take paper records and make them electronic. The challenge with that is the regulations that came after that legislation didn't actually have a concept of interoperability really fundamentally built into them. So we took paper silos and we created digital silos, which is fantastic. And And then everybody looked at each other and said, we spent $30 billion. Why isn't all this data moving around? Well, we didn't actually fundamentally drive interoperability. And so last week, the Office of the National Coordinator of Health IT, as well as CMS, released another 1,000 pages worth of regulations. And to boil 1,000 pages down, they essentially say, we're going to push all of the data to a patient-centered fashion. The burden for accomplishing that task is going to be on healthcare providers. Healthcare providers, as defined by any hospital, any physician, any home care, any durable medical equipment agency, you name it, provider, is now going to be tasked with the burden of not only providing that information in its entirety, but doing so in a relatively technologically advanced fashion using a protocol called FHIR, F-H-I-R if you need to Google that, and to do so in a very timely fashion. And the net result of that is going to be a real shakeup of kind of the mentality around how we look at interoperability. HIPAA was always interpreted, not necessarily designed to, but always interpreted as something that would try and create privacy. So you had things like minimum necessary, and a various set of rules that said, I'm only going to release a patient's information if these criteria are met. And that's being spun on its head. So it's now moving into a direction that says, I am going to always release the patient's information unless it meets one of these exceptions. And I'm going to do so fast. I'm going to do so through technology, advanced technology, and I'm going to do so in its entirety. So the natural swing of that is going to be quite interesting to watch because there's a lot of liability questions that go along with that, a lot of privacy questions, a lot of innovation in the application space because the intent is to drive innovation, and a lot of questions around how do providers bear that burden, how do they work with their technology vendors to accomplish this task. And so it'll be interesting to see how that plays out. And if you think kind of in the employer space, if all this data is flowing around and everybody's got an app that has their patient information on it, what's to prevent one of those models from going out and looking at your employee population and steering certain benefits in certain ways based on the health or unhealth of those individuals? And so absolutely. A lot of interesting questions that get popped up, but it's going to be probably for the next 5 to 7 years the most monumental shift in interoperability that we've seen since the original HITECH Act.
So is this a repeat of a few years ago where we get a bunch of direction and then it doesn't happen, or do you think it's I'm curious what everybody else thinks as to
well, I'll tell you mine. The difference, in 2008, it was all carrot. So like I mentioned, there was $30 billion that went out there. This time it's all stick. So some of the fines, depending on how it's set up for what they call information blocking, some of the fines can go as high as $1 million per incident. So if you think a healthcare provider is not going to get their attention, that if they screw up, they're going to cost them $1 million, I think it's going to be quite impactful.
Yeah.
What about the medical legal ramifications of this? If you're a physician, for example, different.
Yeah,
it is.
I mean, thinking about providers, like, what are they going to have to start doing when they have, when they're getting patient-originated data, right? If I'm walking into the office and I'm bringing my, Apple Health, and they're starting to get this data because it's very easy. What sort of changes in the calculus, and how do you think they're going to start to respond or change the way they behave? Anybody?
Well, I can tell you how my doctor.
I'll be glad to answer.
Yeah.
Go ahead.
I can tell you how my doctor deals with it. I take my blood sugar twice a day, and I've got a little meter that prints out everything, and I take that into the doctor every time I see him, and he says, "Oh, that looks good," throws it away, and has another A1C done.
Yep. Well, I think, to your point, I think it's really information overload for doctors. It's really hard to practice today. I mean, there's value-based care and a lot of economic pressures, and there's a huge volume. We were just talking about the volume of medical literature and trying to keep up with all of that. And then when you think about physicians getting data from apps, I mean, pretty much physicians are not in this mix yet. I mean, you see payers, consumers, employers, but not really physicians, like prescribing apps. And when you think about it, you know, how will they deal with this data and what will be the liability? Say someone has a really high glucose reading and they get that information every day. What are they going to do with that? Or, you know, if they get it from 10,000 patients every day in a health system, who's going to review that data? There's a bunch of liability there. So it's very possible that providers don't even want to get that type of data. So you have to figure out how they're going to leverage all these apps that are in the marketplace. And I think also, how do physicians get reimbursed? I mean, if they're reviewing so much more data, what's the model? How are you going to align all the incentives? So I think, you know, there needs to be a lot more thinking about what data could providers use, how could they use it, and how would they be reimbursed for incorporating it into their practice.
Yeah, I think some of the complexity, it'll lead down, you know, some of the pathways of artificial intelligence and machine learning. I always use the framework of data, information, knowledge, wisdom. We're at the stage, you know, data, it's just a bunch of random facts out there. Information, you can at least understand which facts go together. Knowledge, you're connecting the dots between them. Wisdom, you actually know which dots are meaningful. We're kind of at the stage of this explosion where it's just a whole bunch of data. Mm-hmm. To your point, the doctor just looks at it and says, okay, that's great, and tosses it. It's ultimately going to have to be some element of artificial intelligence or machine learning that's able to comb through that and at least elevate it to a semblance of information or knowledge so that a human can look at it and say, okay, I know what's important here, and I can take it into an actual decision. Because I just think there's no viable pathway anywhere in the future that any human is going to be able to dissect the level of information that's coming out and reach any conclusion that's able to be made a healthcare decision off of.
Totally agree.
Yeah, let me piggyback on that a little bit. Each year, over 400,000 patients die in hospitals of cardiac arrest or respiratory failure. These patients didn't die without leaving a lot of clues behind. But the fact is that data overwhelming, no human being can, whether it be a doctor, nurse, or whoever, can analyze that and come to any conclusions for it to help those patients. Last year, the FDA approved a company out of Campbell, California, called Wave Computing that uses artificial intelligence and algorithms to be able to take those data and give you a 6-hour early warning system of patients that are beginning to fail. And this can be tremendous. But once again, that's one company. They just got approval. Who knows if they're going to be commercially successful or not. But artificial intelligence and algorithms to be able to condense that. And I think I told you guys a story when we were in there talking on our own. When I started my career after the Marine Corps in healthcare, it was as a detail man. I carried a bag and I was a sales representative for Ciba Pharmaceuticals. And I had a rural territory, South Georgia, part of Alabama. And one of my duties was whenever a paper came out or a clinical study came out that was favorable to my drug, I'd go in and I'd tell the doctor in his office about it, and they were happy to see me. It was a real service. Also, I was oftentimes the only person that could string a whole sentence together that they saw that day. But now, the volume of clinical data, the volume of scientific papers that's out there, no amount of sales reps are going to be able to pass that information along. J&J has recently partnered with IBM on the Watson system to try to teach it how to read scientific papers and analyze those in clinical data reports. Now, this is called Wave Computing, and their algorithm is able to, this is the Watson system, and right now they've uploaded 3.5 billion papers, and they're uploading 27,000 new ones a day. But until we can take that and turn that not into data, but have something to be able to evaluate it and turn that into knowledge, and then the doctor turn it into wisdom, it's not going to do us any good.
Yeah. Do you have something to say?
No, I was just going to add in one additional element, because I think it's interesting that you end up in a circular pathway. One of the challenges most recently with a lot of the artificial intelligence and machine learning that is out there, that looks specifically at patients' records. So when you step out of reading, scholarly articles or other kinds of things, and you get into a patient's pathology report, as an example, you get back to physician behavior. Because every physician documents slightly differently. Some of them will document the tumor and staging and metastasis of a cancer cell in codified fashion. Some of them will put it in as a note. Some of them will dictate it. Some of them will store that in a certain part of the EMR. Others will store it in another. And so they all have different methodologies or standard operating procedures on how they approach documentation, largely driven off of historical paradigms associated with payment. And so when you circularize this back to machine learning, how do you code machine learning to read different records differently unless you actually understand how they were initially documented and intended, because they weren't put in the same way? And so as an industry, you could look at that as, never going to be able to accomplish this. Healthcare is 20 years behind, kind of the typical commentary. You can also look at it as it's a huge opportunity for innovation, because there's thousands of businesses that can be born to try and figure out how do you accomplish that. And at the end of the day, I've been always a firm believer, literally for the last 20 years I've been in the space. It all begins and ends with that relationship between a patient and their physician. And you've got to figure out a way to crack that nut of how does a patient interact with that doctor, and how does that doctor behave with that patient community in a way that you can, solve this problem.
Yeah.
Do you want to say something?
I wanted to say something about AI. So, in the space that I'm in, where I'm working with employers and health plans a lot, AI is more than just using data from healthcare organizations or vendors. I mean, they're starting to incorporate consumer behavior data, buying data, data on clicks, genomic data. So there's a lot that's going into predicting what's going to happen with a patient. And there's a lot of personalized messaging happening with all the healthcare aggregators. For example, if someone lives in a zip code where the air quality is bad, and that can be predicted for tomorrow, and they have asthma, there can be a push message to that person saying, hey, the quality's going to be bad tomorrow, make sure you take your medication or stay indoors or whatever it is. It's a little Big Brother-ish, but they try to kind of send these messages in a little bit of a generic way so people don't realize all the time that they're being targeted. But those are the kinds of environmental data and other kinds of things that are being used now in terms of AI and health.
This is also fascinating. So let's maybe take a little bit of a change, and let's talk a little bit about what you talked about. Regulations being a little bit of a thorn in the side of potentially innovative things within healthcare. And as we know, HIPAA and FDA regulations can really get in the way. What areas are you seeing true innovations coming from? Like, where are people starting to push ahead, even though there are these sorts of barriers in front of them? Are there any particular examples that you're seeing of innovation coming even in spite of regulation? Maybe the answer is no.
Well, I would look at the regulations that just recently came out as intended, whether they actually accomplish it or not, intended to actually spurn innovation. Versus be a thorn. So that's the intent. So I think there will be a good amount that comes out of that. In terms of HIPAA, it has historically been a challenge for innovation, because that has been interpreted as a key kind of blocker of the liquidity of data for patients and their care teams. And I'm familiar with the FDA, like 510K and other types of regulations there, less so in terms of how they've been a challenge. But I do know that what I have seen in terms of a lot of companies jumping into the space is they're looking for those early partners and those those entities, whether it's an employer or a provider or consumers themselves, to lean in and prove it. And so I think as an industry, we've moved from a model where we're waiting until it becomes enterprise ready and fully checks all the box, into a model of let's launch it and see if it takes off, and then we're going to figure out how to make that next leap.
Taking a page out of Uber's book.
That's correct.
Yes,
Yeah.
exactly.
Yeah.
Mm-hmm.
And Steve, I mean, what are you seeing in terms of pharma? I mean, where are the innovations coming from there? Is it a similar sort of pattern, or is it small startups?
Well, in my opinion, I've worked in big pharma and I've worked in small entrepreneurial skunk works. And as far as I'm concerned, almost all the innovations come out of the small operations. You have better communication when it's small like that. There is a way, though, that big pharma can become a whole lot more innovative and make a big difference. And that is if they take all the money that they've got and pour it into machine learning drug design, where you can take artificial intelligence and come up with a molecule that specifically targets a given disease. That could be fantastic. And basically, you could take 50 dedicated people and do away with 5,000 people that are currently in R&D. I know that doesn't go very well with your particular relative, but I've seen it. I mean, big pharma, at least in my experience, just gets tied up in their underwear, and they're so risk averse, whereas you have clear communications and you have risk taking and you have dedicated people in the small groups. But there's a company called in silico that is now building such a drug discovery engine based on AI. And I think those kind of things are really going to turn everything on its head.
Very cool. I'm going to jump to some questions that have been submitted. And if you want to submit one, I think it was up on the screen, but there are already a lot, so I don't think we'll get through all of these. So let's start with one. What do you see as the most promising or innovative things that allow people to seek a better care or a better quality of life? Maybe Louise, you want to take that?
Yep. So I think a few things. One is virtual care. I think that virtual care is, again, going to make care much more convenient. It's going to make care better in terms of being able to follow people longitudinally, because you can't come into your doctor's office all the time, but being able to monitor people, being able to see people on, HIPAA-compliant apps and talk with them and find out how they're doing, I think is really going to revolutionize care. I think also genomics is becoming incredibly important in terms of identifying risk and also in terms of, as you said, targeting therapies. So I think that's something that's really going to change. I think therapies that are curing disease, I mean, when you think about it, and you can speak more to this on pharmaceuticals, hepatitis C is cured today. I mean, that is truly amazing. And then I think navigation services, so there are a lot of these that are popping up and they're being carved out of health plans. So member services and clinical services are being carved out so that when you call, you have one number on the back of your insurance card. When you call that place, they're trying to use transactions that are administrative to move into clinically appropriate types of interactions. So for example, if you call a regular health plan for an ID card, member services, they'll say, sure, we'll send you an ID card, and that's usually the end of the call. These navigation advocacy organizations, they want to know, well, okay, sure, we'll send you your ID card, but what's going on? Why do you need your ID card? Oh, you're having a service. Oh, what are you having? Oh, you're having an MRI. Well, first of all, where are you having it? Oh, you're having it at the hospital. It's going to cost you $1,000. If you have it down the street, it's going to cost you $300. So maybe you should consider that, and they'll talk about quality. But then they'll also say, like, why are you having the MRI? Oh, you have back pain, really? Well, let me have you talk to a nurse to make sure, that you understand about the MRI and the questions you should ask your doctor. And that leads to a whole trail of what's going on. Whether this person's had back pain, are they getting the right care? So I think those types of services are going to change healthcare a lot. There are also services that are offering second expert medical opinions, and actually can call up and just talk to a doctor and say, this is my issue and I don't know where to get care or what to do, and they'll kind of give you a consult. So I think those kinds of vendors, and they also aggregate a lot of data and do a lot of targeting, are going to change healthcare.
Yeah, I think, just to piggyback, I was going to say care navigation. I think you're spot on with that.
Yeah.
I think care navigation is a huge change to the paradigm of how individuals interact with the healthcare ecosystem. It's scary when you have an acute event or a chronic event. It's just a scary situation. So I think having an advocate and a navigator that can help you through that is key. There's two other ones, one that kind of piggybacks that, and then one that's a little bit more in the life sciences space. There is a huge movement towards how do you bring preventative care out to the world. I think everybody knows that the population that has Fitbits and Apple Watches are not the population that's really costly for us to manage. And so there is a huge swath of innovation. I was talking to somebody the other day who was, I don't know if this is actually happening or whether it was just conceptual, but I was talking to somebody the other day that had expressed to me, if you look at Walmart, they've done studies that say 25 to 30% of every Walmart's parking lot is actually not used on a regular basis. So how do they wipe out that portion of the parking lot, stand up primary care clinics, get mobile primary care clinics onto buses and trailers like they have mobile radiology systems nowadays? And how do you start to bring that out to the community and kind of bring the community that's most costly into the healthcare ecosystem in a preventative fashion? So I think there's a lot in that space.
I agree.
And then something that you mentioned, Steve, in terms of early detection. I think that's early detection in all of its variants is going to be a key aspect. And there's been a lot going on around things like liquid biopsies in oncology that you no longer actually have to go into the physical tumor in order to capture that and study it and understand it. You can actually grab a simple sample of blood and look at the DNA that's coming off of the tumors in blood and understand what's going on and be able to more early detect what could occur or may be occurring and bring that in. So I think that preventative construct is huge.
Yeah.
Well, if you got to pick just one, in my opinion, the only thing more powerful than genetic editing is artificial intelligence. And the money is getting put behind that too. In the last 5 years, startup healthcare AI companies have raised over $4 billion over 576 deals. Okay? In that same 5-year period, the FDA has approved at fast track routes 70 devices and tools that are associated with AI. NVIDIA, the graphics processing folks, the CEO there had a nice quote. He said, "Software ate the world, but artificial intelligence will eat software."
It's a little terrifying. This is an interesting question. So the question is, it sounds like universal healthcare would be the best way to address data interoperability. What do you guys think? Which is actually kind of interesting because one of the things we were talking about was in Israel there's 4 HMOs. They compete for subscribers. There's easy sort of migration between the two, and certainly the payer landscape here makes things more difficult. But what do you guys think?
I'll chime in first. So I'm not sure if anybody's familiar with the concept of the triple aim, something that was released many years ago, actually. But 3-legged stool, you got quality of care, cost of care, and total population health. And the complexity of that is we're constantly trying to balance this 3-legged stool. So there's ways you could look at it. Other countries that do have universal health care have solved data interoperability like that because the government makes a decision, and guess what? It flows that way. There are obviously downsides to that as well, depending on where you land in the political spectrum. But you have that three-legged balance that you kind of constantly have to really think about. My personal belief is that CMS has enough of a bat in terms of how much of the population they already pay for, that if they really put the emphasis behind their regulations, the industry is going to be forced to follow.
Interesting.
Well, in the political spectrum, I fall a little bit right of Genghis Khan. But I really think that the quality is an issue of those three-legged stools that I find that universal health care doesn't seem to solve too awfully well. And I'm against the government running anything because I haven't seen them do that very well on anything before. But that's my personal political opinion.
And I guess my opinion is that even if we had universal health care, and my personal belief is everybody should have a basic level of insurance because everybody should have a basic level of health care and prevention. But if you have universal health care, today the government vends out Medicare and Medicaid to private companies. I mean, I worked for insurers and I was the medical director over Medicare. So I'm not sure that the government would be administering it, and I think the data would be all chopped up. That's what I think would happen.
Fascinating. This is an interesting question, and I thought it might be worth talking about. Do you think it's noteworthy that none of the apps we've been talking about address physician burnout? That's something that you think about.
Yeah, so I have several clients that are healthcare organizations, and I've worked with a lot of them on physician burnout. And so I don't know of any apps, but there are some podcasts that are addressing physician burnout. And there are some solutions that some of the employers that I work with have put in place that are related to apps. For example, one employer who did a survey and found that people were getting stressed because they lived in a high traffic area and they didn't have time to drop their kids off in the morning and get to the hospital and get parking. So they gave people coupons for Uber. So they're kind of using different kinds of apps to address physician burnout. They were doing things like meal delivery, and there are some apps you can use with like Blue Apron and things like that. So they're not using health apps, but they're using different apps.
Interesting. So let's see. Just kind of closing up because we only have a couple minutes here. If those of us in the audience, and I'm including myself, remember just one thing from the discussion that you would want them to take away, what would that be? Maybe we can just go down the row. Louise, start with you.
I think one thing that's really important, and it relates to what I just said, is that we're talking about all this great technology and all this money invested, and I know I largely deal with insured populations, but we have to remember to apply all of these innovations to the whole population, whether they have public insurance, private insurance, or no insurance. I think it's very important that we solve problems for everybody, not just for those that might have insurance.
These are disruptive technologies, and disruptive technologies create disruptive times. And such times always bring out resistance because disruptive times topple existing market leaders and emerge from that new decision makers. The takeaway that I would recommend is that don't be siding with the resistance. Be an active part of the change because these changes, artificial intelligence, wearable health monitors, and the patient themselves playing a bigger part in their care will change everything.
Yeah, I'd say innovation's a marathon, not a sprint. Every major disruptive technology that I've seen that's made it over the chasm and has really gained massive adoption is kind of the overnight success that was 20 years in the making. So I think if I were taking away one thing, there's going to be a lot of innovation over the next 5, 10, 15 years to drive this. But it's not going to be somebody that creates something and a month later all of a sudden it's changed the world. It's going to be stuff that's already been happening and that starts now that all of a sudden 5, 6, 7 years from now people look at and say, oh my gosh, this is amazing. We've changed the world. And in hindsight, you'll look at that as overnight. In reality, it's the hard work that people have put in for decades that it actually drives that change.
Take the internet, for example.
I think that's a great place to end. So thank you to our panelists.
Really nice meeting you.
Last announcement, come to the next event. And, you know, one of the things that we as an organization always look for is feedback from people who attend in our membership on what kind of topics you'd like for us to feature in the second half of the year. So if you go to the same Slido where you submitted questions and go to polls, just tell us what are the topics that you're interested in learning more about. You know, we're constantly looking for feedback, constantly looking for ideas. Thank you all. Come, see you next month.